First of all, thank you so much for spending some time and answering the questions that we have. And the first question I have is about that dreaded bone marrow biopsy. And no patient likes to get one, but it seems that some doctors do them more often than others. And I was wondering, first of all, what's your recommendation about how often or at what point in a patient's myeloma journey should they be having a bone marrow biopsy? And once they have that bone marrow biopsy, I know you talked a little bit about the FISH testing should be done with the aspirate. Are there any other tests that we should be considering? And when you're talking about the FISH testing, could you, because as I understand that, it's you have to have certain targets for the FISH, what are the main targets our doctors should be ordering the test for, and if we had a biopsy and the FISH testing wasn't done and you're currently in remission, should you have another biopsy to have that done or wait until relapse? I know that was a loaded question, but I'm sure.
No, they're great questions, Cindy. Thank you. So in general, patients absolutely need a bone marrow biopsy at diagnosis. When the FISH testing is done, now most labs have set it up that the physician doesn't have to ask for all the specific targets. They would just ask for the myeloma panel. And there's been greater standardization amongst our pathologists to determine what are the key genetic areas that we're fishing for, as it were, as I mentioned earlier. Now, in terms of the frequency of repeating them, thankfully the majority of patients with myeloma do have an abnormality in the blood test that we can follow, because as you even said off the start, bone marrow tests aren't what you're going to do on Friday night for fun. They're a little bit dreaded, and so we wouldn't want to necessarily do them every month. I would normally do the second bone marrow at usually one of two places. One, if the disease has responded and is now growing again and there's evidence of relapse, I want a new picture of where we are. Secondly, if someone has been treated and we want to confirm the depth of their response, it looks like they might be in a complete remission, and that may or may not influence if they're going to get more treatment, whether that's after a bone marrow transplant or just with chemotherapy. We may want to get a fuller picture. Even though the blood tests tell us a lot, the bone marrow is really the definitive time. I do think sometimes I see a lot of people getting maybe extra bone marrows than they really need, but it can do that. We would typically do a bone marrow test on everyone about 100 days after transplant. The third most common time to do a bone marrow test would be if there's something that doesn't fit, that the blood counts are dropping, for example, but yet the protein tests didn't go up in the way that one would expect. And if we're worried that something else may have happened in the bone marrow, we know that unfortunately a certain, albeit small, percentage of patients with myeloma can have other problems in their bone marrow, like what we call myelodysplastic syndrome or other conditions where the bone marrow is not functioning very well.
Okay, great. Thank you. Next question I have is about flow cytometry. I'm hearing a lot of things about MRD negativity, and that the next generation flow can help determine this. And I just was wondering if you could explain a little bit about what flow cytometry is, what kind of information does it give you that the other testing might not give you? If you are not in a CR, is there any reason for you to get a flow cytometry test, and is this something that all myeloma patients should be actively seeking?
Great questions. So flow cytometry is actually just a method whereby we literally flow cells through this little machine, and based on what's on their surface, we can determine what kind of cells they are. So we do flow cytometry for a lot of different blood cancers to determine are these abnormal or normal white blood cells or platelets or red blood cells, etc. In myeloma, we think of, and I think in the context that you're asking, is when someone has had treatment and their bone marrow is pretty well clean of plasma cells, there aren't very many of the myeloma cells left, we can do very specific flow cytometry testing to see Are there little bits of disease yet that aren't easily measured in the blood? What you mentioned is a minimal residual disease. And there's different ways of doing it. There's two primary ways of doing it. One is through flow cytometry, and the other is through what's called deep sequencing. Right now, again, even we just met as an international myeloma community last week in Rome to discuss how we're going to roll this out, because there's still lots of different ways of doing it, and we haven't quite come to a common currency on it, but we're coming very close to it. That detecting the presence of ongoing disease, even though the disease appears to be in a complete remission by the blood test and the bone marrow, this MRD or minimal residual disease testing may be of value because it may cause us to treat a patient longer or to give them more therapy. So again, for the listeners, we're not rushing out everybody and telling them go to your doctor and get flow cytometry, minimal residual disease testing, but it is something that will, before long, be quite likely a bigger part of how we evaluate the disease.
Okay, great. Now, talking about the era of precision medicine, I am hearing a lot about precision medicine and sequencing of tumors and sequencing of your whole genome. How does that relate to the diagnostic test that we should be having for myeloma? Should we be having this deep sequencing or whole genome sequencing done, or not at this point, or next generation, or the gene expression profile? Are they all kind of related?
Well, you've got all the tough questions tonight for me, hey? No, these are important. This is where we're looking. So when you talk about precision medicine or personalized medicine or individualized medicine, where someone is getting their whole genome tested, this is something that even just a few years ago would have cost $100,000 or more, and is now getting cheaper and cheaper, literally by the minute. It's probably cheaper now than it was when we started the teleconference. But it is something that we're frankly not recommending for all of our patients right away, because we're still not sure what to do with all of that information. There are hyper-specialized areas like we have here at Mayo Clinic where we're understanding this, and we're doing it more broadly in individuals with and without cancers to help understand their whole, if you will, genetic signature, or their genetic patterns that might indicate certain diseases more likely to occur than others. For the myeloma patients listening right now, again, I've said this a couple of times, but it's something that I want them to sort of have an ear to the ground on, that we're not immediately rushing out to have everyone have their whole genome sequenced, or absolutely everyone getting gene expression profiling on their plasma cells in their bone marrow, but something that will likely be a significant part of what we do in the future to understand not just myeloma, but all diseases and how they interact in someone's genetic signature.
Okay. And my last question, I think, is a little bit easier, is about the role of the PET-CT scan in the myeloma patient. How often should one be done? Is it something that should be done periodically to compare to past ones? When should we have these testing? When should we have the PET-CT scan done?
Yeah, so the PET-CT scan is something that is allowable now in myeloma, and there's some centers that are doing it on everybody at diagnosis. I would suggest it's not always necessary if someone has easily measurable disease otherwise. The challenge is, of course, how frequently does it need to be done? If someone is a non-secretory patient, as I mentioned before, where we can't measure their disease by any other means, then that's pretty important. We tend to follow it somewhere around sometimes as often as every 3 months, but more likely closer to every 6 months. But, for any one of these tests, you always have to ask yourself, is the result of the good test going to change my management? We all kind of want to know what's going on with the disease, but if it's not going to change what you do right away, if we say we're going to give you these 3 months of treatment, then we don't want to do the testing too often, because none of these tests are perfect, and of course they cost, and some of them come with some risk because some of them bear radiation. But in general, a PET scan can be helpful in capturing the accurate diagnosis at the start, and maybe occasionally being done later if we're following a patient that way, but not routinely done in the majority of myeloma patients on a regular basis.
Okay, thank you so much for those great answers. Gary, back to you.
Yes, thanks, Cindy. I appreciate it. Jack, you online? Jack Aiello?
You hear me?
Yeah, I can hear you now. Jack,
okay.
Your questions?
So I had a couple. I'll follow up on your question, Gary, about mSmart. The protocol calls for patients, newly diagnosed patients who have trisomies only, to get Revlimid Dex as treatment, and that's a standard risk patient. And my quick question is, what the heck are trisomies? But my bigger question is there will be some doctors who say, well, we think we really ought to go with a 3-drug regimen of Revlimid, Velcade, Dex, rather than starting anybody with Rev Dex. And so are there trials that show, for example, for standard risk patients that Rev Dex is just as effective as Revlimid, Velcade Dex?
So great question. So trisomies, as you can understand the word tri referring to 3, it just refers to the fact that there is a subset of myeloma patients who have a third or an extra copy of certain chromosomes. They tend to be the odd numbered chromosomes, 3, 5, 7, 9, etc. And the reason why we focus a bit on trisomies is we've known, especially from our large Mayo Clinic database, that many of these patients are the ones who actually live the longest with myeloma. Now, sometimes, even paradoxically, these are patients that don't often get into a complete remission. They kind of have this slow-growing version of myeloma. And it brings up, really a fantastic question that you asked, Jack. And this is one where I sometimes joke and say, you put 10 myeloma doctors in a room and you have 12 opinions, right? I mean, it's hard for us to completely agree on everything. But there is no doubt that in general, the more treatment you use, of course there's going to be a better response. 3 is always going to be better than 2 as long as the drugs are tolerated. 4 is going to be more effective than 3 as long as the drugs are tolerated. And we can keep using the number higher and higher. I sometimes use the analogy, despite being the Canadian pacifist here, saying, if I'm going to battle, if I take all 5 branches of the military, I've got a really good chance of winning the battle. But the question is, do I really need all 5? Could I have been just as successful with 4, with 3, with 2, and with 1? And in our experience, many of these patients with trisomies have done very well with less treatment. Because in general, I think most patients would prefer to have less drugs. There's less toxicity, meaning less side effects from it, and it's cheaper, and it preserves options for the future. There are some studies that will soon be released that are comparing RD versus RVD, as you said, or lenalidomide dex versus lenalidomide bortezomib dex. I'm not going to be surprised when they, generally speaking, will show there's an advantage to the 3 over the 2. But this is where an individualized discussion has to be had with each patient. And this is really the essence of mSmart, of saying every patient has to be looked at individually. In one individual patient, I might say, you know what, your disease is not that fast growing, you've got a trisomy. Why don't we start with just lenalidomide dexamethasone? I do understand the argument that we want the best for our patients, but the best doesn't necessarily mean the most. It's the most appropriate therapy for them. And in some patients, we might start that way and say, you know what, we're not getting the response we want, we should add bortezomib. Or some we might say, no, we need to use the 3-drug combination from the very start. And that's a complex situation, but it's an important one. And we want to highlight the point that you don't just say everybody gets cut with the same cloth, a cookie-cutter approach, and everyone gets the same regimen. We give people based on individual factors.
And just clarifying for me, actually, with respect to trisomies again, do some myeloma patients not have trisomies at all?
Correct, yes.
Okay, all right. And then my other question, kind of a general question that I think a lot of people don't understand. It's my understanding that an MRI is better for diagnosing focal lesions rather than lytic lesions. Can you explain the difference?
Yes, so what we've come to appreciate is that we've just revised the diagnostic criteria for myeloma. We used to talk always about what we called CRAB, or C-R-A-B, where someone was defined as having myeloma if they had a high calcium, if the R stands for renal insufficiency, they had kidney damage, A stands for anemia, they had a low hemoglobin, or B, they had bone disease, which was usually defined by a lytic lesion. Lytic just means like a thinned out piece of bone that sometimes ends up fracturing and actually breaking the bone. We've added a few criteria to that now, saying that sometimes on MRI and even to a certain degree on PET scan or CT scan or whole body CT scan as it's sometimes called now, we can actually see that within someone's bone marrow, there's a focal, which means a discrete area where it looks like the bone marrow is growing a little bit out of control, or the bone is going to be affected because of that area. That's not normally something you'd see on just a plain X-ray. And that, if you will, upgrades, unfortunately, someone from a smoldering condition to a true active myeloma that needs to be treated. And so that's why an MRI can be quite helpful. And if someone, we're not sure they really have active myeloma or not, they've got this bad protein, but we're not sure if it's doing any damage, we'll do an MRI to see if that person lands in the smoldering group versus the true active multiple myeloma group, because that will have broad implications as to how a patient should be treated. Because if they have evidence of focal or discrete lesions that we see in an MRI, more than one of them, that tells us that we need to treat them as if they had true myeloma. As I sometimes say to patients, I don't have to wait for someone to be falling down the cliff to know they're in trouble if they're running towards a cliff. And if we see that it's coming soon, we need to do something. By contrast, we have a lot of people who just have a little bit of an abnormal protein in their blood, but they don't have true myeloma. We don't want to overtreat those individuals either.
Perfect.
Does that help answer?
Yeah, it's perfect. I always appreciate your explanations. And Gary, I have another question, but I'll turn it back over to you to let other people ask. Gary, are you there?
Thank you, Jack. We have the next panelist. Matt, you're on. You have some questions for the doctor?
I am here. I guess we lost Gary. Thanks for your time, doctor. I have a couple questions. Mine are pretty simple. My first one's a two-parter. How are diagnostics different for bone-impacted patients versus kidney-impacted patients? And can a person's myeloma change, from being kidney to bone and is there a way, or should that be tracked, or can you be pretty confident that it will just stay what it is?
No, you might think those are simple questions, Matt, but they're great questions. In terms of the diagnosis, we still do it the same way. We try not to think of people as saying you've got the kidney myeloma, whereas someone else has the bone myeloma. Really, a patient has myeloma, and it may infiltrate the kidney, it may infiltrate the bone, or both. And unfortunately, it can change with time, where one person can maybe don't have as much bone involvement early on, and later on it can affect their bone. Later on it can affect their kidney. This is an unfortunate disease where it has the ability to evolve. Sometimes we call it clonal evolution, meaning the disease itself can be more aggressive and can actually change a little bit with time. And whereas it appeared in one way before, it doesn't always come back the same way. So we have some initially, maybe they don't have any bone disease or any kidney disease, and it happens later. So I think it's important that everyone get appropriately evaluated and monitored. And the one thing in particular we want to watch for patients with kidney involvement or potential kidney involvement are those light chains. So I described earlier that the bad protein of myeloma is kind of this big chunky protein that's got little bits on the sides of it. And those little bits on the sides of it are called light chains, and those can shed. And those light chains are so small that when they travel through your blood and they make it to the kidney, and the kidney filters and sort of cleans all of our blood, they're small enough that they kind of get plugged into the kidney. And so we sometimes call this light chain disease, or where these light chains can be very toxic to the kidney. So there are times with patients who have high light chains in their blood, we're more nervous about their kidneys, and we're watching their kidneys. Sometimes at diagnosis, for example, someone can have skyrocketing levels of light chains. It's critical that we get those light chains down very quickly, because if they circulate in the blood for too long, they're definitely going to cause kidney damage and sometimes even kidney failure.
Okay, thanks. And related to kidneys, obviously I'm kidney impacted, which is why I'm asking these questions. But other than light chains, what else should a person be tracking, and even related to kind of living with the disease and being on a renal diet, which I know Gary was on for a while as well. Are there things, markers that we can look at that would maybe let the person relax their diet and not be overly concerned about their kidneys for a while, or or generally should you just always stick to taking care of the kidney?
Well, we all want to hug our kidneys, right? Because they're such an important part of our bodies. We want to support kidney health. I think there's some basic things. I mean, the most critical piece we've learned over the years, the best way to protect a kidney in a patient with myeloma is to control their myeloma, because that is the key feature. And some patients were able to completely reverse their kidney damage with good treatment for the myeloma. But unfortunately, as you mentioned, there are a lot of people who are left with some damage is permanent. By the time we get there, to mop up things, there's already enough water damage that there's permanent damage to the kidney. And so in that situation, it's hard to be very general, but there are a couple of key principles. Things that all of us want to do in kidney health. I live in Arizona, and it's hot. I mean, today we almost broke a record. I think it was 106 degrees. So I drink a lot of water when I'm down here because it's hot. Hydration is an important part of our kidney protection. We don't want to make our kidneys concentrate. We want to make sure that they're very well hydrated, as it were. You mentioned the renal diet, and yes, there are certain aspects of the diet. I get asked all the time in myeloma, what's the best myeloma diet? Well, there really isn't. There have been some bits and pieces here and there to support one thing or another, but to be honest, it tends to be very motherhood-like statements. We all should have a balanced diet. But in patients who have kidney involvement, we want to be careful of high salt and high protein loads that can be a bit more tricky for the kidney. Other thing that we found is very important is to beware of anything else that can hurt the kidney. Dehydration, of course, can hurt the kidney, but there are certain drugs. Sometimes when people take non-steroidal anti-inflammatories in high amounts or other drugs, that can also, certain antibiotics and so on, can affect the kidney. So we strongly recommend before people take drugs that they discuss them with their physician, because whereas a person with a normal kidney function can take those drugs and it's not going to affect them, someone who has kidney damage, it can affect them adversely.